Yeah, maybe wave if you can.
I could try to change that resolution a little
bit. Okay. So sorry about all those technical difficulties there, but thanks everyone who's attending. Mike Bevilacqua, I'm one of the nephrologists over in Fraser, and here we're talking a little bit about the things I've been working on over the last couple of years, and just giving an update on where things stand with all the various PKD initiatives that I've been working on. So there's a few things that we're going to talk about. I've got kind of three sets of things. Are we good there? Okay. Yeah, so I've got kind of three sets of things we're going to discuss. Thanks a lot. If the slides, oh, right. This computer does nothing. It's this computer. So we're going to talk about where things are at with our provincial registry. Probably a lot of the time I'm going to spend talking about some of the imaging type initiatives that we've been working on. We've got some exciting stuff to share there. And then we're going to talk about some clinical tools that are coming forward. So to start with the registry, just as a reminder, why did we even go about this exercise when we have something like PROMIS that is already a provincial level database? And really it's because we identified a gap, and it was specific to diseases like this where we really want to focus on the earlier stage of the disease. Because traditionally we know that people are registered in PROMIS when they access some kind of renal agency service. So whether that's a CKD clinic or a medication or obviously dialysis or transplant, which tends to be, when people are later in their disease, but we kind of had a gap in the earlier stage people. So as a reminder by numbers, when we first started this exercise in PROMIS, we had about 450 PKD patients, or at least listed as having PKD of their diagnosis. Most of those were on transplant and dialysis. And it's obviously a very, very gross underestimate, because if you were going to use population level estimates, we'd assume that there's somewhere between 5,000 to 10,000 British Columbians living with PKD. So only knowing about 450 obviously meant that we had just the very tip of the iceberg, the kind of most progressed people. So that's why we decided to go about actually trying to have a more comprehensive registry. And the goal of this, there was actually several different goals. One is that we wanted to just have a better understanding of PKD in this province. Everywhere in the PKD world, people just kind of assume that it's no different wherever you go, but we don't know that for sure. This is all based on just a couple of different geographic areas, so we don't know if PKD in BC is different than somewhere else. We definitely need better information if we're going to be informing kind of quality improvement type initiatives at all levels, provincial levels and right down to the individual clinician level. And there's obviously a research role of something like a registry as well. So we started this, we kind of started building it back in late 2015. We started actually registering people in spring of 2016. So now we're at about a couple of years, about 2 years now, and we can see how things are going. And I'd say that things are actually going quite well. So we have now just under 1,000 people registered, and we're seeing registration across the province. So this first slide just shows that we have people in different health authorities that are registering. But this is the slide that I'm actually happiest about that when we look at it. So what we're seeing is that we are achieving our goal of registering those earlier stage people. So if you look at those different bars, the different colors, we have blue, all of the various dialysis modalities. We have orange, that's transplant. And the gray bar is people who are not on dialysis or transplant. So in other words, kind of pre-end stage patients. And you can see that when we started this back in 2015, we didn't have as many of those. And as time goes on, although our transplant and dialysis numbers are relatively similar, which kind of makes sense, you can see that gray bar just rising and rising and rising. So as time goes on, we're really starting to capture a lot of those earlier stage patients. We can break it down, and this is just the people who are not who have not reached end stage, not on dialysis or transplant. And again, you can see these bars 45 to 60 and 60 above, things like that. Those are people that were almost non-existent in PROMIS before when we started all of this. And we're starting to capture them more and more. This one on the side where we have no value, this is kind of a thing to do with when they were registered and some registration issues. But at least we're starting to see people across the spectrum of disease being registered. Now we can start to actually ask the registry some questions. We can start to figure out some things about PKD since we're starting to get some numbers. So one of the first things is just where are we managing these patients? And I've kind of split it into two halves of the screen. On the left side of the screen, you have kind of your renal replacement modalities. On the right side, you have people who are pre-end stage. And we can see that we're actually starting to get a good number of people in your individual offices. Those are people that we did not at all exist in PROMIS before we started this. So we're starting to get a fair number of those people registered. And it also shows us a bit about how we're treating PKD in BC, which is kind of nice. So of our patients who reached end stage with PKD, 68% of them have been transplanted. That's fantastic. That really speaks to the great work that the transplant teams are doing. Of the people on dialysis modalities, 40% of them are on home dialysis modalities. We have a good number who are on PD, something that other places or some places think is impossible to put a patient with PKD on PD, but yet we have a fair number of those people as well. So now you can start to see the types of things we can get out of having a provincial level registry. And when we start looking at it, we can start even asking more refined questions. We know that blood pressure management is absolutely crucial in polycystic disease. We have things like the HALT PKD trial telling us that. So we can start to say, how are we doing with that? You can see that we're starting to get some blood pressure information out of this. And we see that we're doing okay. It's kind of hard to see a provincial level mean, but that's where blood pressure is. And we're starting to build medication profile. I'll say that the fact that we have this much information there already is actually kind of very encouraging to me, because none of this is mandatory. So people are getting some of this information in their earlier stage patients, and it's really going to help as we move forward. We decided to do a little bit of a dive, and this was actually Taewon did most of this work, one of the incoming fellows, and he actually went very similar to the GN registry. The PKD registry is also capturing dictations as people send them in, and so he went back to see, what kind of information is in there. And this is kind of telling in a few ways. So when, you don't have to read all the text on that slide, but basically we looked at things like family history, renal imaging, and those types of things. And we found that from the dictations, we weren't getting a lot of that. I'll kind of point out the second line. So the majority of patients, 61%, had no documented renal imaging. Now, of course, that doesn't mean that they didn't have imaging done. And in something like PKD, they would have had imaging done at some point in their lives. This is just kind of telling us that this probably isn't the way to get at that information. Because, if you met somebody 5 years ago, you probably in your first dictation very clearly talked about what their imaging was, and then you never really talked about it again, because why would you in your subsequent dictations? So going through the dictations to harvest the information probably isn't going to be where we're going. So it was kind of nice to look at this and kind of discover that that's the case. So one of the next steps, and something you'll probably see coming out, we're looking to pilot this in a couple of sites, is actually having an information form with much more kind of granular tick box level data, something that lends itself much better to the data format of PROMIS. And it's kind of nice. This might look like a big form, and you say, why would I do this when I'm seeing my patients? Actually, most of these things are designed to be filled out by patients themselves. So it's kind of very easy to understand information that will correspond very nicely to fields that we can build in PROMIS, and we can start to actually get at some of that clinical information and get it into our database. So this is coming soon, and we're going to be trying this out in a couple of sites, and then we'll roll it out if it does work well. And then where is this all going? I mean, it's all nice, well and good to have clinical information in PROMIS, and it seems like a lot of extra work, but there really has to be some value to the clinicians and to the patients if we're going to keep going with this. And I think the most immediate thing that I see is that you can kind of do, we're getting to a point where you can start to do practice audits on it. And by practice audits, I don't mean I'm going to sit there and police what you're doing. I mean, you can actually take a step back and say, how am I doing with my PKD patients? How many of them are in a KCC versus my office? What does my blood pressure control look like? What kind of medications am I using? And then as we learn things, like, for example, a couple years ago when we learned about strict blood pressure control, you can actually say, oh, we now have a new blood pressure target. What does my blood pressure control look like in my PKD patients? And who can I call up and improve things? And as more treatments start to come out with the disease, this will also be a very quick and easy way to say, okay, I now know that this type of patient category is a candidate for some new treatment. Do I have anybody like that in my practice? So it's going to be kind of an ongoing quality improvement level or tool that you can use at many levels. We can do this provincially, and the goal is to do this right down to the individual nephrologist's office. Once we start to see that this is doable, I think how it'll start is we'll probably do some of these. We'll probably pull some of these and send reports to people, see if it's useful. But the ideal end state is that you could be doing this as a self-assessment. Remembering, of course, this is something everyone needs to do as part of their MOCAP, class 3 type thing is self-assessment, and it's just a very helpful thing to see to check in how you're doing every now and again. So pretty exciting that we're actually starting to yield some information. You can start to see the power that a registry can have. There's also some other things that we can do with it. So one of the things that spurred this is the fact that there was a new drug, and we wanted to see how people are doing, or people are using it. We can kind of see that since everybody who would be using tolvaptan is registered in PROMIS through McDonald's, we can kind of see how things are going. It also gives us a picture of where we're at in terms of using this drug. When you look at the means in terms of GFRs and age, that all kind of sounds good. But you kind of look at that spread, and you can see where the quality improvement of this comes in. You can see maybe there's obviously individual circumstances, but that person started at GFR of 17, makes you, kind of think about what's going on there. And this is where a tool like this can really help us see how we're using medications. These are about the only couple slides I'm actually ever going to even talk about tolvaptan today, because some people mention that's all I ever seem to talk about. But just out of interest, there's a couple of things about usage of this across Canada, and these are some of the things that we pick up in our registry as well. We can see what discontinuation rates are. Ours currently are a bit higher than other places, and that's again, you can start to see how we can start digging down and asking questions as to why is it that our discontinuation rate for this medication is higher than in other places. Some information on coverage. And this is, again, just out of general interest. This is national level data in terms of discontinuation and hepatic monitoring. And things are actually pretty consistent to what we had seen in the trial in terms of the incidence of transaminitis. But what we're seeing is that with the monitoring pathway in place, there's very, very few severe liver injuries. So I'm done with that. Now I'll talk about the stuff that back to the registry and stuff that I'm really excited about. The third goal that we were talking about was actually helping in research efforts. And one of the big national SPORE studies that's going on right now is with PKD. And there's a proposed kind of multi-phase study where we're going to be doing some stuff more about disease trajectories, so with imaging and genetics. And then there's some actually I'd say very exciting medication repurposing trials of very easy to access, cheap medications that look very promising in PKD. And so this kind of shows where we stand with our registry. So the target enrollment for the country is 800 patients. With our registry, we were able to go back and put in a simple query and say, using the enrollment criteria, how many patients do we have that meet it? And we immediately spat out 490 people, which is, a big chunk of the actual desired national registry. And we can actually say, if we group them into specific sites, over 400 of them are in 3 distinct areas that we could probably focus a research in. So you can see how as things come out and as we're doing research, we have this ability now to say, okay, you need a couple hundred patients, we can do that. And so I think we'll be very, very involved in this as time goes on. So some pretty exciting stuff. I think, it was a lot of work by a lot of people in this room to get this registry going, and we're now starting to see some benefits of it. So I think this is just really the beginning of what we're going to be able to do with this. So that was imaging, that was our registry. Now, imaging is probably what I wanted to talk about most of the time. And I think, again, we have some pretty exciting stuff going on here. So there's a few things we'll talk about. There's our standardization efforts and really how we're going to bring more modern imaging into clinical use here in BC. So we talked about this in the past. We had already gone through and standardized our ultrasound reporting. You should now, and I'm seeing them come through as well, you start seeing more useful ultrasound reports, not just patient has cysts on both kidneys. It should actually start to be more detailed information. The one reminder I'll give people is you do have to write PKD somewhere on the rec, because the problem is the radiologist sees so many ultrasounds and so many of the cystic disease are not PKD that you kind of have to say, query polycystic disease or known polycystic disease. The term has to be in there somewhere to trigger them to use these standardized formatting, but you should be seeing better information. So that was ultrasound, but that was arguably kind of one of the easier things to standardize, and as I know, it's still not perfect across the province. So the question I keep hearing is, what about total kidney volume? This is what I actually want. So this is to get down to what we needed here in BC. We did a bit of a questionnaire and needs assessment. This was about half a year ago. This is something I did actually as part of one of my master's projects. And we were trying to get at what do people want here in BC? What are you doing and what do you want? So we asked some of the questions that came out of this was, one, is this something people are even doing? Are people even wanting to get extra imaging in their PKD patients? And by and away, the answer is yes. Both of those top bars are yes, you want to do some kind of size-based assessment. We say, would you do this just at diagnosis, or is this something that you would do on a routine or repeated basis through someone's disease trajectory? And then most people are saying, this isn't just a diagnosis thing. Even later on, I want repeat imaging to help me with some of my decision making. So there's a big appetite for imaging in PKD. But then we start to get into the nitty-gritty of it. And one of the, I think, the more telling questions is, we asked, does the availability of imaging influence your decision to get imaging? And by and away, the answer is yes. So in other words, you're not thinking, do I want this clinically? You're thinking, can I actually even get this imaging test before you order it? Yeah, just a reminder, maybe everyone, if you could just mute if you're on one of the peripheral sites. There's a bit of background noise there. And then this is, I think, one of the most telling slides that came out of this. So, sorry, the text is a little bit small there, but we have two questions. On the left, we said, what imaging tests are you currently using for PKD? And on the right, we say, what imaging tests would you like to use for PKD in a perfect world if access was not an issue? And what we see is that most people right now are currently using ultrasound and CT. But if they were in a world where imaging wasn't an issue, they'd be using ultrasound and MRI. That's a very encouraging answer to me, because people are still saying, yeah, there's great things you can get out of ultrasounds. It's not like every single individual needs an MRI like you would if you were at the Mayo Clinic or in Toronto with York Pay. People are saying ultrasound has a role. But for the cross-sectional imaging, there's a definite shift here that people would rather be using MRI than CT. And, oh, I think I duplicated that slide. This was that access question. So putting it all together, we see there was a few things that came out of this. We saw that people are definitely using imaging-based assessments and size-based assessments. That's great. You know, in other places, people haven't taken this up as quickly. Remember, this is something that's only been around for a few years now. So the fact that there's an appetite to take this up is fantastic. But what we really got out of it is that there's a wish list of things. If we had a wish list that we could fulfill to bring imaging into BC, we'd want a few things. We would want our test to be accurate, but out of this needs assessments, we'd say that it would have to be feasible in different practice settings. It would have to be readily available. And of course, we need something that's acceptable to the patients as well. So we did a little pilot study on this to get exactly down to this question. This is all very hot off the press stuff. The manuscript is just kind of in the last stages of being submitted, but I'm happy to share the results with you guys already. So what this was is a pilot study that we did in Vancouver General and St. Paul's. And what we were trying to do is see exactly that. We wanted to identify some imaging modalities and measurement methods, and I'll talk about that in a lot more in the next slides. Some measurement modalities some imaging modalities and measurement methods that are accurate and feasible across the province. We do not want everybody to have to come down to Vancouver to get a 1-hour MRI to get their size assessed. That is not an answer. We want a test that can be done where people live and is very accurate. So we did a few things. So what we did is we recruited 30 patients. Why we specifically said we wanted a GFR over 45 is we wanted people to derive some kind of personal benefit out of the study. So somebody who could actually benefit from knowing what their total kidney volume is. If they're already very, very far progressed, it's arguably less important. So 30 patients, and then what we did is we did a convenience sampling. So this is not random or anything by any means. What we were trying to do is actually select people out with some, especially if they had previous imaging, with some way of figuring out that we were representing the entire spectrum. So in other words, we didn't want just 30 patients with kind of massively enlarged kidneys. We wanted to see that this worked across the entire spectrum of different renal sizes. And so once we got our patients, what they did is they came in, and in one day they got every test. So they got 3 different imaging tests. So they got what we call a low-dose CT, an ultra-low-dose CT, and I'll describe what those mean in a second, and an MRI. That ultra-low-dose CT was also reconstructed. So that actually yields 4 different images per patient, giving us 120 unique imaging sets. So even with 30 patients, we have a lot of data here and a lot of imaging. So what do I mean by these different imaging modalities? So the low-dose CT is actually, I put KUB, but it's actually already a lower dose protocol than your standard abdominal KUB. And that's what you see on the imaging there on the left. And then we have this ultra-low dose. So the reason that we're putting these different dosing methods is that people have always been hesitant to use CT scan because of the radiation exposure, but absolutely nobody has looked at this in the last 10 years. And the technology that's out there right now with the CT scans to reduce dose is just tremendous. And we'll talk about exactly how low that ultra-low dose is in just a minute. But so when you look at the images, they both look like kind of bubbly kidneys with a lot of granularity. But you can see that the one on the right-hand side, it's a little fuzzier than the KUB. Kind of makes sense because of the fact that it's a lower radiation exposure. But then they can take that ultra-low dose CT, so that's kind of the raw images on the left, and they can apply something called MBIR, that's modeling-based iterative reconstruction, where basically a computer that does physics and all kinds of wizardry that's much more sophisticated than me can actually do some boundary refinement and sharpen those images. And one of the nice things is that kidneys in general, and specifically cystic kidneys, are almost the perfect thing to subject to this, because you have all these little bubbles of water that you're contrasting with the surrounding tissue. So it's almost like they have their own built-in contrast, because that's what this iterative reconstruction is really good at doing, is distinguishing between kind of solid and liquid and things like that. So it works very nicely for polycystic kidneys. And you can see that now when we put this side by side to the low-dose CT scan, although it's still not as perfect resolution as the low-dose CT scan, it's very good. And especially when we're talking about total kidney volume, and really we want to see the outsides of the kidney, it looks quite nice. It's not the type of detail that if you wanted to look for anything else in the abdomen you could find, but specifically for just looking at the kidneys, these images at least look very nice. So those are our imaging modalities that we looked at. And then we also looked at a bunch of different measurement methods. So we have the images, now we have to actually figure out a volume. So the gold standard is what we call manual planimetry. So what that is essentially some radiologist somewhere just traces around the kidneys on every single slice. And to put this in perspective, with the MRIs, you're talking about, if someone's got big kidneys, you're probably up to 200 slices. With the CT scans, you're probably around 100 slices or so. So that takes about 45 minutes a scan. That's obviously not at all feasible anywhere in a clinical settings. I describe this as kind of monks by candlelight type of work. I think when I saw how they had to do this, I understand why most radiology departments are on the ground floor, because if they were on the top floor, you'd throw yourself off the building if you had to do this more than once. It's just absolutely not feasible. If you're in a study somewhere at the Mayo Clinic where you have millions of dollars and you can pay fellows to do this and chain them to their desk and interpret scans, great, but anywhere else, it's absolutely not feasible. So we looked at some other tools. One of them is that we leaned on heavily is kind of the ellipsoid-based measurement, and that's taking advantage of the fact that kidneys, even polycystic kidneys, are roughly ellipsoid-shaped. So with 3 measurements, a long axis and 2 cross-sectional dimensions, you can come up with an approximation of what the volume is. This takes less than 5 minutes a scan, and this gets into the realm of being clinically feasible. So we had all these images, and we said, how does everything compare? So we have this big table here, and you can see that we have the scan types and the volume equations. And when you look at this is the correlations between the two. You see lots of 9s, which is a good thing. You want to see lots of 9s if you're doing your correlation table like this. We also did our inter-rater reliability or interclass coefficient, also lots of 9s there. So it's very reproducible and highly correlated to this gold standard method of planimetry. They did do planimetry for each of the 30 patients. They almost killed me by the end of it, despite warning them that it was going to be very time intensive, but they did it, and compared to the gold standard, it's very, very good. So we'd look at this, and you'd almost think we could stop there. We can kind of pick whatever method we want, and we see all these 9s, so great, we're off to the races. But the problem with just looking at a raw correlation with something like this is that in polycystic kidney disease, you have a very wide range of different kidney sizes. So again, this is more statistical wizardry than perhaps I'm fit to explain, but the essence of it when you're looking at a correlation is that if you have a value that has a wide range of answers, it's easy to get a very high correlation. So in other words, if all the radiologist could do is tell you that this 5-liter kidney was not 450 mils, you end up with an excellent correlation just because of the fact that it's spread across so many different ranges. So what we did to kind of refine and actually answer this question of how variable are the different measurements is we did this, which is called a Bland-Altman analysis. So in the x-axis, we have the different kidney volumes. And then what we have here is the percent difference between the gold standard and the measurement obtained with that method. And now you can see that we actually start to get a feel for what's the variability. What you're trying to see when you look at these types of graphs is 2 things. So we have this line that is the mean, and you want to see that that's pretty close to 0. If it was above 0 by a fair amount, it would tell you that you're consistently overestimating volumes. If it was below, it would tell you that you're consistently underestimating. So here we see our line is pretty close to 0. And then we want to see what our standard deviation is. What is the variability? How far are these scans going from the true gold standard result? And here, with our low-dose CT scan, it's about 10% is the standard deviation. And we'll talk about what that means in just a second. When we do the ultra-low-dose CT scan, we see that there's actually less agreement or more variability. That standard deviation has gone up to 13%. Still, it looks like excellent correlation. It kind of confirms the fact that this doesn't really change because of our wide range of volumes, but this does. So you can see that this change, and we're tending to overestimate things. But then when we apply that modeling-based iterative reconstruction to those ultra-low dose, it comes right back down again, and the variability is down to 8%, and again, we're seeing our mean closer to 0. We do the same thing for the measurement equations, and I won't get into the details of how they're different in the interest of time, but we have two different ellipsoid calculations, and we kind of compared the two of them. 10%, 10%, so they look quite similar. These dots are now colorful because we've put all of the scan types on one grid there. We did do a third measurement method that's called a mid-slice method based on just one image. It didn't perform as well, and that's why I'm not really dwelling on it here, so we don't need to know the details. So that's all well and good, but I almost may have convinced you that our numbers were deceiving and our variability was more than it looked like by just the correlation. So when we talk about these numbers and we talk about the standard deviation, is 10% too much? Because that sounds like a lot. Saying that there's a standard deviation of 10% in volume sounds like a lot. The pictures that I have here, these are pulled from the original Erasabal paper. This was the paper that originally established that Mayo classification of PKD. And you can see that their numbers look almost identical to ours. They had about 500 patients. This is from the Mayo Clinic, where they do have fellows chained to a desk doing the manual planimetry. And you can see their standard deviation is still 10%. In the body of their paper, they actually very specifically described this and went back and looked, is this contributing to misclassification? Because we know we have that classification with all those colors that I've showed you guys a million times of, A to E. And so with 10%, are we seeing misclassification? And what they found is that it was probably less than 10%. And if you do, it means you might cross one line, but it's not like you're off by a big amount. So in short, they've said that with a standard deviation of 10%, that's more than acceptable to apply this imaging-based classification. That's a very important thing to know, because we're seeing 10% variability, and at least we have reassurance from the literature that that is okay for clinical use to apply this classification. So now we look at it. I had this first graph with all those 9s with the correlations, but we actually do the same thing with those variabilities that we saw. And now you actually start to see some differences between tests. For our imaging modality, we can say that with our ultra-low dose, as expected, there's more variation than the low dose. But when you apply this iterative reconstruction back to the images, it comes back to be very, very similar to the low dose and actually very similar to MRI. So with the reconstruction, those low dose images perform excellently. And when we talk about equations, there were some differences here, but we've identified that our ellipsoid-based equations are acceptable for use here. So probably I think one of the biggest things that came out of this was the radiation exposure, because this is the million-dollar question, right? This is why nobody's using CT, why nobody wants to use CT, is because they say there is too much radiation exposure, especially in something that you might be applying to a young patient, and you may even be doing multiple times. So what we have here at the top is the effective radiation doses in the study. And what we mean by effective dose, that takes into account how much radiation was used and where was it done. So when you're looking at effective doses, the same dose of radiation applied to your hand is a much lower effective dose than that applied to your brain or your abdomen, because it's less likely to cause damage. So it takes into account both the area that you're doing and the dose. So with this effective dose, and this is kind of our standard that we use to compare doses, we saw these two values. If you're like me and you're not a radiologist, it's hard to know what the heck do those numbers mean. Is that good or bad? But when we start comparing it, you actually see where these numbers fall. So even the low dose, which by our study protocol, we probably tended to overexpose people, even the low dose is much lower than things like, for example, a cardiac CT, which every businessman will come into your office having done this as part of his executive health package, and nobody seems to mind 3 millisieverts applied to the chest as a screening tool. But here, with half of that, we can do the kidneys with a traditional low dose. With our ultra-low dose, we're now actually on the order of an abdominal plain film series. And I can't remember the last time I ever thought about radiation dosing when I was ordering a plain film series. But yet, this is almost identical to 3 views of the abdomen. That's how low the radiation doses are with this protocol. So this is very exciting stuff. If you were in a place that this is all you have, I would not be all that concerned about applying this amount of radiation to somebody. Remember that this doesn't tell you anything else. This is a scan if you were doing it just good enough to do total kidney volumes. You can't see if they have, lesions anywhere else in their abdomen. But the fact that it's on the order of a plain film series is quite exciting, actually. So what did we get out of this? We got pretty much exactly what we wanted to. We found that you can get acceptably accurate and precise measurements with several different methods. Of course, you can do this with MRI, but you can do it with just about any CT format. And if you wanted to do a new image, you can actually do it with a very, very low dose of radiation. We can get our measurements in a very short amount of time, less than 5 minutes. So this now gets into clinical feasibility for a clinical radiologist somewhere. One of the things that I mentioned there, kind of the nice thing, because we've shown that these measurements work with as low of a dose as possible of CT exposure, but almost any other traditional protocol has higher doses than that. So kind of the corollary there is if somebody's had a CT scan for any other reason, that image is definitely of sufficient quality to go back and interpret a kidney volume. So when your patient was in emergency 2 years ago because they had abdominal pain, great. You don't even need a new scan. Just pull those images and you can measure it. And it's definitely going to be of good enough quality to do that. So this is the big question now. Okay, great. So we've got it. Now how do we get this out into the world there? So we've done ultrasound. And as I know from talking to people, it's still, the uptake is somewhat variable. You still are seeing some poopy type ultrasound reports, but at least we're getting there. An ultrasound was arguably much easier than this. TKV is coming. So, I get this question a lot. When will I be able to just order a scan and get a total kidney volume? My hope is that by the end of the year or so, we should have at least a standardized protocol put out. I just want to remind people that this is a first in Canada. So even the ultrasounds and definitely total kidney volumes, being able to have a standardized approach across the province, nobody is doing this. We're light years ahead of anyone else already with what we're doing with ultrasound. And by the time we do this, this is going to be, amazing. You'll be at a point where you can order a scan in Prince George, you can order one downtown Vancouver, and they're going to be done the same way and interpreted the same way, and you're going to have comparable results. So we're almost there, and I think it's quite exciting to say that. So that was our big kind of set of imaging things that we've done over the last year. So stay tuned, and you'll definitely be hearing more as those are ready for prime time use. And then the last few things I want to talk about is some of the tools that we're making so that to actually bring out to the clinical world. So I almost always have a shameless plug when I have my talks, and Taiwan is in the middle of helping us out, and we're going to be doing another needs assessment. I know people are sick of seeing surveys come through and everything. But what we want to do is we're now in the next phase of building more clinical tools around PKD, and we want to actually hear from people what's going to be of value to you. So we've got kind of a 5-minute questionnaire that we're going to send out to people to see, and this is your chance. If you have some burning question, something that you want to see us develop at a provincial level and kind of put out there on the website, please give your feedback. Otherwise, we'll just keep guessing and making what we think people want. But in the meantime, so that's coming. Let's talk about what we actually have. So when I say actually have, here's one that's coming soon. I'm going to have this kind of vetted through the MAC first. But based on everything we did with that imaging things, and this I think I've identified as a need from people, we're coming up with an actual kind of one-page FAQ, what's an approach to imaging in PKD? So how do I decide what kind of imaging test to get in my PKD patients? And there's a couple of goals that I had in mind as I made this. We wanted to, some of the values, you want to maximize what information you already have. You want to actually have some kind of structured approach to doing this. And obviously the tests have to focus on clinically available stuff. We don't want to be sending everyone to Vancouver to get a scan. So we're going to get this vetted, but just so you have an idea of what this kind of looks like, because there's a whole bunch of tiny print on there. We're going to kind of go through a few steps as in a document like this. The first step always is to maximize the information you already have. We're in the era, of course, of choosing wisely, and if somebody's already had 1 million scans, it behooves you to use the information from that before you order something new. So that's kind of what this is saying, is go back, look at scans. You can definitely have them reinterpreted. I'm quite sure that, I'm quite sure, they do, the radiologists do have, because everything kind of comes down to this, the radiologists do have a code for reinterpreting an image, and what I've actually done and been very successful with is most of my total kidney volumes actually come from scans that were already done. So I'll pull up that the scan was done 2 years ago. I'll just print out the report and write on it, can you please remeasure this for volumes? And I just say length, width, and depth, send it back to them. And they send it back within a couple of days with those measurements done. It takes them probably about 2 minutes to do, and they're happy to do it. So do use the information that you already have. If you need new tests, okay, how do we approach this? And we go through kind of a structured walkthrough of saying, first, if all you really need is a big, broad estimate, are these kidneys very big or are they close to normal size? Do an ultrasound. Ultrasound's fantastic for that. You don't need an MRI or a CT or anything like that. It's only if you've decided you need to go onto cross-sectional imaging, then we talk about how you do it. And you can see, I won't go through all the text on this, but it's almost a reminder to check again if they've ever had a scan done before. And then if not, it talks about the ways that we can do this. So this will be out, and it'll be, and once we kind of have this fed, it'll be on the website with the rest of our PKD tools. We already have a lot of tools available on the website. In case people haven't looked, this is another shameless plug to go on the Renal Agency website. Under Health Professionals, we actually have a PKD tab, and there's a lot of good things on there. So for our registry, there's an FAQ. Oh, I didn't fill it in. It's an FAQ actually for patients, because it's come up every now and again that when people hear about this, they say, do we need to consent patients and all this? The short answer is no, you don't need to consent patients. This is something we do in routine clinical care. But because of this, we've actually made a patient-level FAQ of why does this exist, what's happening to my information. It's kind of a description of how it's all protected. So some patients quite like that, to see that. And we also have instructions for how the heck to register somebody in Promise. This is, of course, going to be redone again now that we're kind of revamping the registration thing in Promise. But if anybody's having difficulty in your offices, there's instructions. There's even a YouTube video that the Promise guys made that shows how they go through and do it. And then we've got, one of the other things that we have a lot of forms for is we have stuff around tolvaptan use. I mentioned it because I've actually heard of this from people around the country, that a lot of people are using our forms. People actually quite like these, especially we have patient-level information forms that says what is this drug and how does it work. And we have provider-level forms, more detail about what you should be thinking, with all the pre-printed stuff on there. So that's out there now. We've got some stuff that is external to our Renal Agency website. So there's an online calculator for the Mayo classification. I don't know if anybody has ever used this, but it was clearly made by some IT person or engineer somewhere at the Mayo Clinic because it's incredibly user-unfriendly. This is where Daniel comes in, of course, and it's now on the QX Calculate app, so a very easy-to-use, user-friendly punch in your button and it spits out your score for you. So it's on the QX Calculate app. And then there's this document that I was involved in, and other people that kind of have some more detailed treatment recommendations. Also, it's available on the QX Calculate app if you just go through. So we've got some tools out there that are available for you. And then the last thing, just a bit of an update, because I think people are starting to hear whisperings of it, is one of the things that I'm working on now is actually starting to develop a PKD clinic. So what do I mean by that? And some tools within our existing KCC. So I think we're getting to kind of a bit of a crossroads here where this is becoming a disease that I think we really need to change our mindset about and change the way that we approach it. This used to be people that we would see once a year and kind of check in, and we didn't really have a lot to do or a lot to offer them. Whereas we definitely have learned a lot about this disease. We know that there's a big burden of symptoms that have probably flown under the radar that we weren't addressing. We know that there's a lot of work to do in terms of prognostication and assessment. And treatments are out now. We have one treatment. To me, this is kind of a tip of the iceberg or flash in the pan type of thing. Where this field is going is the treatments are going to get very complex very soon. Before long, we're going to have people on multi-drug treatment for PKD, kind of like we do for things like transplant or HIV, and you're actually going to be selecting cocktails of medications for people. So I think that this is only going to get more complicated as time goes on. So we kind of need a way to deal with this. So I mention this because we're kind of uniquely poised in BC. We are definitely the envy of the country when it comes to our network of CKD clinics. We have an amazing infrastructure in place that has already done our patients a world of good. We have 14 CKD clinics across the country. There have been no dedicated PKD clinics popping up. There's actually it's closer to 30 now across the country, of which so far precisely 0 have been in BC. But these are popping up across the country. So what do I mean by this? Everyone, I said this was something I was doing, and people imagine that I was out and building a new building and things like that. It's essentially within our existing KCC. I've just kind of segregated, think of it more like a PKD stream than a PKD clinic. So all the patients, the way it works in Fraser is a lot of them come to me already for kind of a second opinion or referral. And then of that, I've selected a small subset that I think these people really would benefit from a multidisciplinary clinic like we already have built. To give you a picture of where we're at, I've got about a dozen people right now. This makes it sound like I've got this big giant thing out there. I've got about a dozen people that we're essentially piloting some stuff on. And this is very much right now, it's become an iterative process. So this is something that we've applied. If anyone's listening who has any influence on this, we've applied for RRP funding. And what we want to do is as we go, kind of evaluate the tools we have. We're going to be looking at several things. So we have the easy stuff we've done. We have lab requisitions and promise flow sheets that can spit out, and we've already done that. We've modified our kind of clinic visit sheet. We've developed some specific interventions. I think dietary interventions are a huge one, especially patients who are treated on tolvaptan. A good dietary intervention can mean the difference between peeing 6 liters a day and peeing 3 liters a day. So it really is important to have these people have access to that. And then there's some things that we're kind of developing specific care plans, something like a Cardex where you can kind of just say, okay, when was the last time I did imaging? When was the last time this person had an aneurysm monitoring? When is it due again? Some very kind of just easy to use things. So this is, although we say that it's up and running, this is very, very much still in its infancy. That's why it's still my baby, as I say. But we're going to be evaluating this as it rolls forward. So, within kind of the year horizon time frame, we've got some process indicators, and we're going to be getting some feedback from our patients who are actually going through this and who are involved to see if this is something that's useful and how do we make this the most useful for them. So stay tuned. I mean, this is something that's just very, very early. Once we actually have some of these tools developed and evaluated and have gone through the ringer and everything, then this is when we're going to start sharing them. It's a little bit early yet to do that. If anybody wants to be involved and wants to, try this out in their area as well, I'm more than happy to kind of discuss and share absolutely everything we have. But as things are more refined, that's when we'll be posting them. And to me, the ideal future state is that we already have this network. And you can see here now I've said PKD services as opposed to clinics because people makes it sound like that's some separate entity. What I really think is that we're going to end up with streams within our KCC. We'll have a PKD stream. And if we have a network of this sharing best practices across the province like we already do better than anybody else for CKD, I think we'll be offering our patients a world of good. I really do. So this is where things are going on the long-term horizon. And that, I feel like I've talked a mile a minute to make up for our slow start there, but that's kind of where we're at right now. So we've talked about our registry, some of the really exciting imaging stuff we have coming. Please do fill out that survey when you see it probably within the next week, so we can figure out where we need to go in the future. And then as things keep coming out, they'll be all there on the Renal Agency website. So with that, I'll kind of open it up to any questions that anybody might have. Maybe we'll start over in the distributed sites if anyone has a question. Otherwise, here in the room? Yes, yeah. Okay.
Is it possible that we in BC do not have higher rate of discontinuation of tolvaptan, that we just have better data and we know actually what is the true rate of discontinuation?
So the question was, as regards, I showed this slide of about tolvaptan and discontinuation, that our numbers were a bit higher than the national average. And the question was, is it possible that it's not actually a higher rate, but we're actually tracking it and nobody else is? I don't think that's the case because this is something the manufacturer is tracking very closely. They know everybody who's been prescribed and they know who comes off. I think maybe one of the bigger reasons is our numbers are so small. So we have a very, very small sample size. So if one person discontinues, there's 8% or something discontinuation rate. So I think you'll see it kind of settle out. I mentioned this thing about multidisciplinary clinics. I do think there's a lot of strategies you can apply to keep people on this medication. I've got quite a number of them on now, and I think it requires more work than most things. But yeah, I don't think it's under capture, but it could just be our small numbers actually, or is the bigger thing. Yes?
So with regards to imaging, do you think now we're at a place that you can actually order low-dose CT or not yet?
So the question was, are we at a place where we can order a low-dose CT? I think if you were at St. Paul's, you could, because this is where Cameron Haig is, who did the study. I think how this is going to have to work, is that once we get to the point where it's standardized, I think we'll actually just put a requisition up there on the renal agency website that one page of it will be the protocol. Because there's so many variables here and there's so many different things the radiologist can do that I think it won't just be that you say, oh, PKD, please give me total kidney volume. It'll actually come attached to this other sheet that says this is how the radiologists do it. Because when we've gone and we've talked to the radiologist, this is what they want as well. You know, the radiologists want to provide as helpful information as they can, and they would love it. They might see this, you know, once or twice a year. So they would love somebody telling them when this is requested, this is exactly what you do. And then you're off to the races. So here, I think with discussion, you could. With discussion with your radiologist, you could. And then in the future state, it'll actually come attached to the requisition. I think that's the only way to have it done properly. Great. Well, if anything else comes up, I mean, I'm always available by email. You guys all know how to get a hold of me. And thanks a lot for your attention, everyone.